Thank you, Caitlin. Thank you very much. Thank you to Bobby Jones, Chiari and Syringomyelia Foundation for asking me to answer some questions tonight. As Caitlin said, I'm a pediatric neurosurgeon specializing in Chiari, Syringomyelia, tethered spinal cord, dysraphism, hydrocephalus. I also do peripheral nerve surgery. So those are, my specialties. Actually, we got some really good questions, so I thought we would just do the format of answering questions.
Awesome.
That's okay.
That's great. Oh, and I will mention for everyone that's on, if something pops into your head that you come up with a question as we go, please use the chat function. I'll put a little message in there, but you can ask questions in the chat, and then as we go throughout the night, we can ask those questions as well. But for now, I'm going to start, I think, with that second question that you were referring to earlier before we got on the video. So as schools across the country release their safe return plans for the 2020 and 2021 school year, parents are going to be faced with some tough decisions deciding whether to send their kid back to school or to have them doing that distance learning. So COVID is an ongoing question with a lot of patients who have Chiari and Syringomyelia just because of the nature of the multiple comorbid conditions that can come along with them. So really, do you have any advice for parents specifically of children with Chiari or Syringomyelia, particularly in areas that are current hotspots and presumably if there are future hotspots? Is it safe to send the kids back to school if that's the local area's decision, or especially if the school is not mandating masks, or should they remain doing the distance learning? What do you think?
So this is a multi-layered question, right? We can start with specifically, are the Chiari and tethered cord Syringomyelia patients more at risk for illness? Are they immunocompromised? Generally, Chiari, tethered cord, no, but about 20% of those patients have connective tissue disorder. And the connective tissue disorder patients are considered immunocompromised. So, I mean, people are very, very right to be concerned. I'm concerned about my kids going back to school. And I don't think any final decisions have been made. So is it safe? No. But can we mitigate the risks? Masks, hand washing, it's all less of an issue for our older kids in high school. It's pretty scary for the young ones. I think the schools are going to do the best they can to, socially distant, to have everything disinfected, frequent hand washing, hand sanitizer, and distancing, and doing as much as they can outside, particularly in the warmer climates. They should be able to do that. But if you have a child who has had, several Chiari surgeries, several shunt surgeries, has hydrocephalus also, has connective tissue disorder, and has been frequently ill, which there is a subset of our patients who have problems with sleep apnea, don't sleep well, have a suppressed immune system for those reasons, and have frequent illnesses throughout childhood. That population, I think, should not go to school in the fall. They should stay home. The learning is not as good unless your parents happen to be teachers, which is not most of us.
Yeah, no, that's true. And arguably, I mean, I know if I was afraid of being sick, I wouldn't be able to pay attention even very well in school. That would be me personally. But so kind of related to that, and I've even been looking into this, there's been a lot of research coming out about COVID in general. I'm having such a hard time even keeping up because the papers, there's like hundreds of papers a day. It's obscene. But there have been a couple that have been coming out talking about neurological problems, particularly in the more severe COVID patients. Are you seeing any kind of, I guess this is completely anecdotal based on your practice, but are you seeing patients with Chiari and Syringomyelia who have been having COVID, or even if you are seeing them, are they having some sort of complications that maybe would be something concerning as far as neurological conditions are concerned?
I haven't seen increased cases of COVID among the Chiari and Syringomyelia patients. I have one patient who got it and wasn't able to come down for her visit even before we were doing primarily telehealth visits. She had to stay home. And that's the only one I can think of several hundred that we've seen in the last few months. So I don't think there's an increased incidence among Chiari and Syringomyelia patients. There are neurologic complications of COVID. You know, the patients are getting encephalopathy, not all of them, but a lot of them are getting an encephalopathy, and they develop a hypercoagulable state, so they develop blood clots in the legs, DVTs, pulmonary emboli in the lungs, and they are also getting strokes in the brain.
Oh, I just had a follow-up question. I just lost it. That's embarrassing. I have it. Would you say that it's possible, and I mean, this is conjecture, that a lot of the patients with Chiari and Syringomyelia maybe aren't getting sick because I think this is a population of people who are a little bit more careful, I would say, to not get sick, and maybe that's part of the reason that we're not seeing a lot of cases in these patients.
Absolutely, absolutely, and you know, also, I mean, in our state, you know, Michigan, Detroit area was a hot spot for a while, and you know, the state was shut down very effectively, and the curve was leveled, and people are continuing to really comply, and I think that applies to our patients. I mean, I can think of one or two patients in the last month who haven't come to the clinic with a mask, and they are, you know, wearing gloves and masks most of the time. So yeah, they're pretty careful, and it's good. I don't think this is the time to relax for anybody. I think you have to really, you can't be too careful right now.
Yeah, no, I agree. Trying to think if there's anything else I want to ask you specific about COVID. I guess break glass in case of emergency. A patient with Chiari or Syringomyelia winds up with COVID disease. What can they expect? Is there any way that there would be a worsening of symptoms maybe from after the COVID kind of strikes? Because I'm thinking you're going to be coughing a lot. What are the types of things that maybe patients should be looking out for, other than obviously they should be resting because they have to get over the virus?
Well, so our Chiari patients, you know, can have respiratory problems primarily from sleep apnea. They can be more susceptible to asthma, allergies. They don't clear secretions well. So in that sense, I think that's how COVID could affect them more. On the other hand, they and their families are more vigilant because they know these are people who can get sick a little more easily and more severely. I think just in general with COVID, you have to have a low threshold to coming into the hospital, getting the oxygen saturation checked, being admitted if your oxygen saturation is low. This is not the time where we say, oh, it's just a virus, it's just a cold, just stay home and lots of fluids and nurse it and you'll be fine. I think, and particularly if there's any shortness of breath, difficulty breathing, those are the most ominous symptoms of COVID that we've seen that really portend somebody getting into trouble. And the interesting thing, if it's interesting, about this particular virus is that a lot of the time people's oxygen saturations are very low and they don't feel air hunger or short of breath or anything like that. They just kind of don't look right. Oh, I have a little trouble breathing, and then the oxygen saturations are very low. So it's just something we have to be very careful with.
Yep. One more question about, not so much about the disease, but more about the place in which we are now because of it in the pandemic. I'm personally interested. So I guess it's subjective, but how useful are you finding telehealth in follow-up for Chiari malformation or Syringomyelia? I know there's evidence that it's useful in surgical follow-ups for some things, but I wonder what's going on at your clinic, and if it's come up, or if it hasn't, what are your thoughts about what could be successfully adapted as far as Chiari surgical follow-up is concerned for telehealth?
Well, I was surprised to see how useful telehealth is. We use primarily Zoom, and the patients can use their phones, their tablets, or their laptops. And of course, the teenagers who are doing this with school are the most facile with it, But it's good. You can show patients the films pretty easily on the screen. You can share. You can show them pictures. So it works out well. There are some things you can't do. And I've gotten pretty creative with testing for things like dysmetria and nystagmus and watching people walk. Be careful, I'm probably going to see your house. And they're not always expecting that. Typically with Zoom, they say all you have to have is a shirt. But,
Yeah.
I'm going to have you walk down the hallway. I'm going to see really a lot more.
My bed is very not made right now, but you can't see it.
And that's fine. That's fine. I'm joking. I mean, obviously, I wouldn't be judging anybody's house, but it is useful. And you can, with creativity, the only things you can't test on an exam with Zoom are reflexes and sensory.
Okay.
And you can't really grade strength. You can tell if somebody's anti-gravity in their arms and legs, but you can't, grade whether it's normal strength or slightly weak. But other than that, it's working out well.
That's really good to know, especially if, knock on wood, that a patient maybe is not doing well a couple of years out of surgery and they say, oh no, I can't go into the clinic. So that's good to know.
Right. Or if they're from another state.
Yeah. Yeah, that's also happening. I think they've relaxed some rules even that physicians can practice out of state, out of licensure, but don't quote me on that. I have to look it up. So I'm going to get to some specific questions now. There's a question that came in particular to headache. So this patient was a young patient, age 5. They had typical Chiari headaches and then had a decompression, but now they're getting frontal headaches. So I guess, is that something that's common to maybe after decompression, the Chiari headache goes away at the back of the head, but now we're getting these frontal headaches that have nothing necessarily to do with the Chiari maybe? What could possibly be the cause of something like that? And how do you approach it?
If the person has already had a decompression and develops frontal or temporal or global headaches, I'd be concerned about hydrocephalus. And, only about 3 to 5% of our Chiari patients end up developing hydrocephalus to the point that they require a shunt. But we see a lot more of them than that who seem to have this elevated intracranial pressure that is it's transient. It goes on for weeks to months after decompression, and then seems to settle down with a little steroids, maybe diamoxacetazolamide or Lasix for 3 months or 6 months, and then we're usually able to wean that off. Now, a 5-year-old is not going to be able to really describe it that much, but headaches in a 5-year-old are very unusual anyway. Typically, kids will keep trying to just keep going, keep playing, keep running around. They don't want to be told to come inside and lie down. They don't want to stop what they're doing. So if they tell you they have a headache, it's probably a horrible headache. It's not a mild headache. If they're having headaches once or twice a week and they're complaining about it, they're really having headaches every day, and it's just severe once or twice a week. So I take those very seriously, and I would be concerned about hydrocephalus in that child.
Okay. A question came up in the chat that's sort of related. Do you recommend decompressing young kids? So I guess age 5 or maybe a little plus or minus. And how does decompression in those young kids affect the outcomes? And this is always an important question. Everyone always asks this. Do you open the dura or do you not? loaded,
No,
I know. But
I think full hour. Okay.
yeah.
With little kids, if they are symptomatic, then I decompress them. I consider decompressing them just as I would anyone else. I have a much lower threshold for symptomatic in a young child because they just don't complain. For example, a 3-year-old is not going to tell you I have numbness and tingling in my hands, but she might tell you it feels like there are bugs crawling on my scalp all the time. Or you might just see her scratching her legs all the time and scratching her feet and not really saying much at all. And those are paresthesias. So typically, if young children are consistently complaining about headaches, neck pain, funny feelings in their arms or legs or scalp, then and MRI shows, Chiari malformation, then I would go ahead and decompress it. And they do very well. That was the next part of it. We recently did a study looking at Chiari malformation and decompressions and stratified them by age groups, 0 to 17, 18 to 40, and then over 40. And over 40 group really includes people up to 60, 70, 80 years old. What we found was that the kids do much better than the other groups as far as outcome and relief of symptoms, and also improvement in non-headache symptoms like weakness and clumsiness and things like that. Interestingly enough, the older patients did not have more complications, so the outcomes were good across the board. The older people had as good outcomes as the 19 to 40-year-old group without an increase in complications.
That's actually jogging my memory. Have you given this talk before? I think you have.
Yes. I did.
Okay.
This is our paper from 2017 that was published in World Neurosurgery.
Yes. All right. I will include a link to that maybe in the chat because I remember that one. But the last question, which I noticed you tried to dodge, is do you open the dura or not?
I always open the dura. I have, over the last 30 years, seen about 5 cases of tumors that were in the fourth ventricle, either choroid plexus papillomas or ependymomas that would not have been found if we hadn't opened the dura. My colleague Arnold Menezes in Iowa has also talked about other problems in the fourth ventricle, arachnoid veils, which are membranes blocking the fourth ventricle, small adhesions, even just a network of adhesions, which if you can picture spider web, it's pretty fine, not that much, but if you really wrap an area in spider web, then you have this thick membrane, and a lot of the time that's what we see. I have recently found cysts in the fourth ventricle that were compressed. So none of this shows on MRI because the tonsils are crowding everything. And typically we don't give gadolinium or contrast when we get an MRI because we're not looking for a tumor. So all you just see is this sort of heterogeneous or homogeneous tissue in the fourth ventricle, which you assume is the tonsils. So I always open the fourth ventricle, partly open the dura to look at the fourth ventricle, partly because there can be other anatomic areas of blockage there, but also because I always resect or shrink the tonsils. The cerebellar tonsils are the bottom of the cerebellum that goes down into the spine. Doesn't have any function that we know of. And more often than not, it just goes down and plugs the flow of fluid again between the brain and the spine. And it typically will be worse because now you have the post-operative scarring that happens plus the crowding. So yes, I always open the dura.
Can you speak a little bit to what the risks are of not opening the dura, or I guess what the risks are of opening it versus not opening it? Because I know even, I'm sure you know about, I think it's Dr. Limbrick is doing that PFD study to kind of figure out if one's better than the other, because right now we don't know. So maybe just talk a little bit about why some people do or don't.
So 70% of neurosurgeons do something to the cerebellar tonsils, either coagulate them or shrink them. You can't do that without opening the dura. So you can extrapolate that at least 70% of people open the dura routinely. That said, any way of doing Chiari decompression has helped people, right? We don't do an operation that doesn't help. So everybody has benefited either from very small exposures, from opening the dura, from not opening the dura, from doing nothing to the tonsils. There's no wrong or right way across the board. About 70 to 80% of the time, only opening the bone does result in a good outcome. But that leaves 20 to 30% of people who will have to have a reoperation, and I don't find that acceptable. So personally, I want to do everything that will guarantee a good outcome as much as possible. So I always open the dura. Recently, last year, we looked at our results in patients who've had surgeries before. And what I was interested in, it was twofold. How do they do? Because the number one question people ask, if you're going to do surgery again, how do I know I won't have to keep having this surgery? You know, if it was scar tissue that formed, everything's scarred down, what's to keep it from scarring down again? So that was the question. Do people continue to have problems? And then the second question is there anything we can see that most of the time or more frequently accounts for this person having to come back? So I looked at graft types. I looked at what was done at surgery. I looked at, you know, the size of exposure, whether the dura was opened, complications afterward. And what I found is, well, first of all, out of 80 patients over 17 years, only none of them had to have surgery again. So I had done the previous surgery in 2 of those 80. But then I had done all of the reoperations. Nobody had to have another operation. So it's not true that they will just scar down again. So it is worth doing. But then the second part of it, the most common finding was that the tonsils were still in.
Mm-hmm.
So essentially, if you leave, you know, this tissue still blocking the fourth ventricle, still coming down into the foramen magnum and down into the spine, then you're more likely to have to come back. But that's not 100%.
Of course. There's actually a question that came in before we started that's sort of relevant to this. How common is it that the duroplasty would actually sag and extend down into the vertebrae from the prior decompression? Because that's kind of what you're talking about happening, some other blockage happening afterward. Why does that happen at all, and what's the significance? What happens from there?
I have occasionally seen that. It should not have clinical significance. So, you know, the short answer, this is obviously a generous graft that was done. It's spacious, and that's what you want. You want a big graft that allows the brain to not be right up against the graft, but allows lots of fluid circulating around the brain, between the brain and the graft, so that it can't get stuck down. So you do want that. And you know, this one was obviously pretty generous. That said, can you really have too much room? As far as the graft, no. People ask about bony decompressions. Can a decompression be too big? Well, of course. But typically, if it's like cutting a hole out of a shelf that a stack of books is sitting on. So if the hole is not as wide as the books, then the books are not going to fall down. And so we make a generous opening, but not, you know, so generous that we end up having sagging of the brain. If you have sagging of the dura, you know, it's not a pretty picture, but I don't think it has clinical significance. One thing I have seen more frequently is what was described as cerebellar slump, and that's been described in the literature, with sagging of the brain. When I have explored those patients, I've actually found that the brain was stuck to the graft. So it's not that the brain had fallen down, it's that the brain was stuck to the graft and actually dragged down. And then when, we opened it and I was able to free the brain from the graft, then we got an MRI down the line and the brain has risen up.
Mm.
And I didn't, put more bone back or do a cranioplasty or anything like that. I just freed the brain from the graft and then, removed that graft so that it wouldn't just get stuck down again and replaced it with something else.
That's good. Also related to that, this came up in the chat. Does the dura scarring from that previous decompression, can that affect the surgical outcome, I guess, of the reoperation? So sure, you're going to go in and try and take that scarring out again and hope that it doesn't come back, but does that affect, I guess, the quality of life and symptomatology after the fact, or do you know?
Oh, I know.
Oh, okay.
that opens up a whole nother can of worms, but it's good, and I'll take you there. Okay, so when we go back in, we remove the scar. I've seen patients with terribly scarred brains. I mean, to the point that the brain and the graft had almost become one, and you had to really kind of carve it down, and then they do well. Another aspect of the study I was talking about from last year was looking at their outcomes, and their outcomes were all good or excellent. So their outcomes were mostly good or excellent, right, on the Chiari outcome scale. Nothing is 100%, but more than 90% of the patients had done very well. If they don't, there are comorbidities that go along with Chiari. There are cousins, and they are connective tissue disorder, ehlers-danlos being the most common in the Chiari patients. There's POTS, postural orthostatic tachycardia syndrome. There is hydrocephalus, communicating hydrocephalus. Those problems are more frequently found in patients who end up needing more surgeries. Mm-hmm. And they're also responsible for the symptoms going forward, more so than the fact that you had another Chiari operation. So if somebody comes back after a repeat Chiari surgery and I do an MRI and I can't find any fault with it, there's nothing tight, there's nothing that looks stuck down, the flow is good, everything looks good, then I look at whether there are comorbidities that account for the continued symptoms.
That's really important. I'm trying to, is there an increased risk of leak, I guess, in a reoperation? And does that, how would that, there is, okay. What's the mechanism of that? And then clinically, what does that mean as far as treatment going forward?
Well, so there's an increased risk of CSF leak. There's an increased risk of hematoma formation, seroma, which is just fluid collections, because it's tissue that has been scarred that's not normal tissue anymore. Then if the person also has connective tissue disorder, they tend not to, they have some challenges with healing in general. That said, we don't see 50%. We see about 10 to 20% increase in complications. So we just, take care of it. And we have a variety of strategies for doing that, depending on how big of a leak and what has happened.
This is just a question that I know we get asked a lot, and I want to bring it up. There's a lot of questions about lumbar puncture and its likelihood of causing CSF leaks. I don't know if you could speak to that a little bit.
So in patients who have a Chiari malformation who do not have symptoms, if they don't have symptoms, then they must have good CSF flow at the base of the skull. If they have good flow, there should not be increased risk in doing a lumbar puncture as long as a large volume of fluid is not done. I wouldn't do a lumbar drain or a high volume lumbar puncture in somebody with a Chiari, even if they were asymptomatic. Okay. It also speaks to, epidural anesthesia for childbirth. We hear that a lot. And if the person is asymptomatic, it should be okay. there is not an increased risk of complications with epidurals in Chiari patients than in the general population. So that's okay. When someone's had a decompression, if they are asymptomatic, or if the films look great, they look like normal, except for the missing bone, then they should still be able to have a lumbar puncture. And sometimes that's useful if you're trying to figure out if somebody has benign intracranial hypertension or communicating hydrocephalus. If someone is symptomatic with a Chiari, I would hesitate to do a lumbar puncture because you can make it worse.
Mm-hmm. There was a follow-up question to something you had mentioned earlier about possibly developing hydrocephalus after surgery. Do you know what the percentage of, I think pediatrics, but I don't know if you could speak to adults as well, what the percentage of patients developing hydrocephalus is after a decompression surgery?
So I don't think they develop hydrocephalus afterwards. I think it was underlying and always there. And then you do the decompression, and then it becomes apparent because the symptoms are so similar. Both conditions have headaches, and global headaches can be Chiari headaches too, as in the case of this little boy, because sometimes because the cerebellar tonsils are plugging the Foramen Magnum and blocking the flow of fluid, people will have global headaches from a general buildup of pressure. Mm. So it's not only occipital headaches that we see with Chiari, but that said, I think it's an underlying problem, and a lot of the time, particularly in the people who have trouble with repeated CSF leaks, that can be the underlying etiology of that. Did I give you? I'm sorry.
You didn't.
We see hydrocephalus in about 10% of Chiari patients, and hydrocephalus to the point that we have to put in a shunt about 3 to 5%. Okay. So that's why I strongly disagree with putting in a shunt in a Chiari patient, even if they are presenting with symptoms that seem more like hydrocephalus, even if they have big ventricles and they have a Chiari. I would always decompress the Chiari first, because if you decompress the Chiari, you open up the fluid pathways and then everything gets better. The person has had one operation and they go on their way. If you put in a shunt, you're putting in a device that can malfunction, get infected for life. Yeah. And you still may have to decompress the Chiari. So I strongly would go the direction of doing Chiari decompression in patients who present with hydrocephalus and Chiari.
I think I know the answer to this, but I'm going to have you speak to it. Has anyone ever looked at abnormal CSF flow specifically in hydrocephalus, so non-Chiari patients? So what does that look like? How do you diagnose it? And what's the prognosis, I guess? How likely are they to do well after surgery, specifically for hydrocephalus?
So a lot of work has been done at Wayne State on this. And particularly when I was there, I remember ongoing studies with dogs, sorry for the dog lovers, but these were animal studies looking at CSF flow in hydrocephalus. There's increased flow, increased CSF secretion and absorption in hydrocephalus. We know that. And I'm sorry, I lost the rest of your question. Sorry.
Studying CSF flow in hydrocephalus specifically. And then I guess what's to be done if it's, how do you diagnose if it's abnormal, really? Is kind of the question.
All right, so there are a variety of ways. So in terms of the research that's been done, yes, there have been flow studies. We know that if someone has obstructive hydrocephalus, they have an anatomic blockage of flow, either from a brain tumor or from a stricture at the base of the skull. Chiari can be an example of that. But Chiari patients, if they have that, they usually also have a degree of decreased absorption at the level of the blood circulation. So most of our CSF is absorbed through the venous pathways into our venous channels in the brain, the venous sinuses, and then absorbed into the circulation. And that's true of everybody. And in hydrocephalus, the flow is increased, it's turbulent, there's increased production of fluid and decreased absorption. And then there also may be an anatomic block, which is obstructive hydrocephalus. How is it treated, you said?
Yeah.
So there are a couple of ways of treating hydrocephalus. Relating specifically to Chiari patients, I like to try Diamox first. Usually, Diamox for some time will get the person away without permanent diversion, which is a shunt. If Diamox is inadequate, then I will proceed with the placement of a ventricular peritoneal shunt. I have occasionally put in a lumbar shunt in a patient who has already had a Chiari decompression. And I don't really like to do it because of the issues I mentioned before. But those are people who've already been decompressed. The base of the skull is just wide open as far as flow. The tonsils are out of the foramen magnum, out of the spine, and the ventricles are extremely small. They're so small that putting a catheter into the brain, into the fluid-filled spaces, which are the ventricles, would almost certainly cause the person to have repeated shunt obstructions because there just wouldn't be any fluid in the space.
There's a question that came up, and I'm going to be frank, I don't know what this is, so I'm going to learn something. Do you believe a cavum septum pellucidum should be addressed, or is it an incidental finding, specifically if a child has had several decompression surgeries?
On the face of it, it's an incidental finding. It's an anatomic variant. However, we have had patients with cysts, septum pellucidum, cavum septum pellucidum, and then a septum pellucidum cyst, really expanding those walls. And they have benefited either from endoscopic fenestration, which is putting in, an endoscope through a burr hole and going into that space and basically opening it up, or actually shunting.
Okay. And if they've had several decompressions, does that make it more or less likely of a good outcome after that burr hole?
We have to really determine if the cavum septum pellucidum is causing the problem. If it's just there and you just have, your two leaves of the septum pellucidum and they happen to be not like this, but separated a little bit, then that's probably not doing anything. If they're bowed out like this, rounded and large, like there is a cyst in there that is under pressure, then the person will, likely get better with drainage of that.
Okay. A question came in. They're having some left-sided numbness coming and going only on the face. It can last a whole day, not necessarily associated with a headache or a migraine. Triptan doesn't change it. They have a stent in the superior sagittal sinus a couple of years ago, but they're also getting left-sided headache, but at different times than the numbness. I assume it never occurs at the same time. So have you seen periodic facial numbness in patients with IIH, I guess specifically? And if so, what's the cause of that?
Wow.
Interesting question.
Yeah, that gets to a lot of issues. Okay, I'm presuming this person also has Chiari. Most symptoms in Chiari are intermittent. They're usually not constant. So intermittent facial numbness is not uncommon at all with Chiari, and also presuming it hasn't been decompressed. Benign intracranial hypertension, or IIH, idiopathic intracranial hypertension, is one of the cousins of Chiari that goes along with it. So I think they are existing together. I don't think the IIH is causing the facial numbness.
Okay. sticking with IAH, there's a question that came in earlier. Can it cause symptoms besides headache and papilledema? Specifically, would it be able to cause any kind of mid or low back pain, throbbing when laying down, or autonomic problems? And I know that's a really loaded question, so I'll let you.
Yeah, it can. It can cause, it's a big mimicker of Chiari, actually.
Oh.
And, you know, the type of communicating hydrocephalus that Chiari patients usually have is very similar to IIH. Which is why it will respond to some degree to Diamox, but not entirely. It's not a cure for that. So yeah, patients can have problems with vision, blurred vision, double vision. They can have, you know, obviously they have headaches. They can have neck pain, back pain, problems with balance. Difficulty with walking is very common. Nausea, dizziness, ringing in the ears. A lot of the similar, you know, symptoms to Chiari.
That's
But
frustrating.
if there is a Chiari on MRI, I would absolutely decompress the Chiari.
Okay.
And then see if the symptoms go away. And most of the time, like 97% of the time, up to a shunt, they do.
That's good. Has anyone ever used abnormalities in CSF flow as an indication of shunt failure?
Oh, people
yes.
do. People do all the time. Abnormalities of CSF flow as an indication of shunt failure.
Mm-hmm.
So if you imagine, okay, someone has Chiari, they have a shunt, you know, decompressed or not decompressed. If the shunt's not working, pressure is building up in the brain. And the difference between IIH and more conventional hydrocephalus is that in hydrocephalus, the ventricles enlarge. In IAH, the brain absorbs the fluid almost like a sponge and just swells. And the fluid spaces don't get bigger, but the whole brain swells. But either way, you have increased pressure, and then that pushes down on the cerebellum and brainstem. So that will cause Chiari symptoms or Chiari-like symptoms, whether or not somebody's been decompressed. So if there's poor flow at the base of the skull and the person has a shunt, you know, that's suggestive that the shunt may not be working. But the shunt, if the Chiari hasn't been decompressed yet, the shunt may not be able to do as much as it needs to do. The person still may need a decompression.
Mm-hmm. What's the likelihood of shunt failure? I know that that's a thing that really irritates a lot of neurosurgeons, but I feel like I have to ask because it's something that building those expectations is really important, I think.
It is 8% per year, shunt malfunction or infection. So over 5 years, about 70% of people have had no problems, no shunt malfunctions, no, you know, infections. They've gone their way. Of the other 30%, about 10% has had, you know, 1 or 2 surgeries over that 5 years. Another 10% has had more problems, you know, but still less than 10 shunt surgeries. And then there's the 10% that you frequently hear about who are in the hospital over and over again with repeated shunt malfunctions. But they are only 10% of the overall group.
That's good. There's an interesting question that just came in. Are you considered to still have Chiari if one of the tonsils is above the foramen magnum, but maybe the other is not? What happens there? Yes.
That's called an asymmetric Chiari.
Okay. If that's found pre-decompression, I imagine you would decompress. But what if that's found after the initial decompression surgery?
Well, the question is the person still having symptoms? Remember, your MRI has cuts that are typically anywhere from 3 to 5 millimeters apart. So within that 3 to 5 millimeters, there can be pathology we just don't see. And a lot of the time when we go to surgery, we find that in measuring the cerebellar tonsils, they are herniated much farther than the lowest extent on the MRI because the slices missed the lowest point. When we have people with very long herniations, you know, more than 20 millimeters, I almost always see those asymmetric. In other words, one side is dominant, longer, and fills the fourth ventricle, and then the other side is just kind of pushed out of the way. It may be long, but typically they're not equally just long and filling the fourth ventricle.
Wow, that's interesting. There was a really good question. Can a syrinx truly be idiopathic and have no cause? So what's the deal with idiopathic syrinx?
Well, so idiopathic really, we didn't find the cause, right? But yes, we can investigate and do studies and not find a cause. But when I have a patient with a syrinx, first I look at the Chiari area, the Foramen Magnum, the occiput down to C2, and I look for a tethered spinal cord, which can also cause a syrinx. We look for any suggestion of a tumor in the spinal cord. If we don't see any of those, trauma can also cause a syrinx. If the person hasn't had a known trauma, I would suggest they probably have one that they had forgotten about, a car accident, something that didn't seem like much at the time, but over time a syrinx developed.
There was a similar question that came up in the chat, sort of related to that trauma question. Have you seen previously asymptomatic patients become symptomatic after that trauma? So concussion or whiplash, even something that might seem small, but was a real trauma to the cord or the brain.
Yes, that's common. That's common. A lot of patients have Chiari and never knew they had Chiari until they were in a car accident, a fall, an assault, hit by a bottle in the cafeteria is my most recent story. These things happen. And then suddenly the person has, all these Chiari symptoms. What happens is that the person, develops some swelling, sometimes some bleeding in the brain and around the base of the skull, and then develops adhesions. And those block the flow of fluid at the base of the skull. So where the person previously had some fluid sneaking around the Chiari, now they don't. Right. And, those problems don't necessarily go away with time.
Right. You were skating by on what you had, but something kind of.
Oh, no, just another thing about the syrinx, looking for a Chiari. A lot of the time, there will be a blockage at the area that is not sort of classic Chiari. Maybe the person has 2-3 millimeters tonsillar herniation instead of, more. Maybe the person has something about the fourth ventricle that just looks funny, looks like a mass, looks like adhesions between the brainstem and the tonsils. And when I have explored those in patients with syrinx, I have found an arachnoid veil, a blockage of the fourth ventricle, something that was causing the syrinx. Oh. And most of the time the syrinx went away or got better.
That's interesting too. So the person who asked a question earlier reworded it. So I'm going to ask it again. So in hydrocephalus specifically, have abnormalities in CSF flow been used as an indication of shunt failure before ventricle enlargement is seen? When shunt failure occurs, over what range and time is surgical intervention necessary or usually done? Yeah.
Every hydrocephalus, every shunt patient is different. Mm-hmm. So, the researchers at Wayne State did look at CSF flow and do flow studies, particularly MRI flow studies in patients with shunts. But if the person was not symptomatic, you wouldn't do anything to the shunt based on the flow study. And if the person were symptomatic and the shunt appeared to be malfunctioning, you got a flow study and it was normal, you would still go ahead and operate on it. So it was more, informational than, really something you could apply. I don't know of cases of early shunt failure being shown by flow study before the ventricle's enlarged. But everybody's ventricles don't enlarge either. With shunt malfunction, you can have ventricles of any size and have a shunt malfunction. So you just have to look at each patient individually and all aspects of it and put the whole picture together.
Good tip. That's important for patients to know too, because you don't want to, you want to make sure everything's clinically relevant before you have brain surgery. There was a question that came in ahead more about scoliosis. So, and tethered cord actually, so we're totally shifting gears, sorry. Does the type of scoliosis, so if it's a C curve, an S curve, a triple S curve, does that matter when you're considering tethered cord surgery? And if it does, how does that change the outcome or even the methodology that you use when you're cutting everybody up?
No, it
okay.
doesn't.
Good.
Typically, patients with tethered cord and scoliosis will not have only scoliosis. They'll typically have other things. There'll be bowel and bladder dysfunction. There will be frequent urinary tract infections. There'll be back pain. There'll be pain in the legs and scoliosis and potentially a syrinx as well. So no, I don't split hairs about the type of scoliosis for tethered cord or for Chiari.
Is scoliosis also common? Is it commonly seen with a syrinx? And in maybe a child, how is something like that treated? Is it treated the same, or does it have to be consulted with maybe an orthopedic surgeon? How does that work clinically going forward?
So syrinx is frequently seen with scoliosis in association with Chiari, but not always. And scoliosis is still, a sign of Chiari, of a Chiari being symptomatic, particularly a progressive scoliosis is an absolute indication to decompress a Chiari malformation. So do we consult with orthopedics? Yes. If it's a mild scoliosis, actually, usually the patient has already seen orthopedics because that's what brought a child to medical attention to the pediatrician was the curvature, or the pediatrician found the scoliosis. And so they usually have already sent the patient to orthopedics, and then orthopedics gets an MRI to make sure there's not a neurologic cause of the scoliosis. And then they come around to us. So we're usually all working together already.
That's good.
If there is a more severe curvature, and I think orthopedics threshold is about 30 degrees, then I think they're going to either need bracing or surgery.
Okay.
Or directly for the scoliosis, even if the Chiari has been decompressed or the spinal cord has been untethered. So that's why we don't want to wait and see if it gets worse. And we, take scoliosis, particularly in a young child, because it's so unusual, or in a male, a teenage male, or a teenage girl who has had progressive scoliosis over months. We want to go ahead and do those because if we decompress the Chiari, a lot of the time the scoliosis will reverse and they won't end up needing bracing or surgery.
That was actually a question that came up as a follow-up. So does decompressing Chiari or untethering a cord improve scoliosis? And how quickly does that improve? Is it lasting?
We usually get x-rays about 6 weeks out, 6 to 12 weeks out, to see, first of all, that the curve is not worsening, and second of all, that it's getting better.
And you usually see it that early?
Oh, yes.
That's good.
Yes.
And that's true also of detethering?
Yes.
Okay.
But again, if it hasn't been going on too long and it's not too severe. Sometimes, scoliosis, if it's more than, 30 or 40 degrees, sometimes it won't reverse, and the person will still need to have surgery for it.
That's a good question, actually. I know this comes up a lot of the time when people call up. Can Chiari, certainly I know Syringomyelia can do permanent damage, but can something like Chiari do permanent damage that maybe can't be reversed after a decompression? I know it's not quite the same as injury to the spine, but I'm curious how that works.
Yes, yes, there are any number of things that can become permanent if a Chiari is causing symptoms, severe symptoms, and it's not addressed. People do develop the variant of idiopathic intracranial hypertension to the point that they lose their vision. And if that goes on for too long, it's not reversible. People lose the facial muscles, or the muscles atrophy in the face so that they almost look like they have a mask-like faces. And a lot of the time these patients are sent to psychiatry for having an abnormal affect, when actually they have a Chiari, which is causing them to not be able to have facial expression the way they should. There's arthrogryposis, in which the fingers kind of draw up like this, and that's from a scoliosis. That will reverse if it hasn't gone on for too long, but if it has, a lot of the time people still have deformities of the hands, loss of muscle in the hands, in the hand intrinsics, weakness in the hands, loss of muscle in the arms from ongoing syrinx. So yeah, and then of course scoliosis is a sign of damage. The syrinx is a sign of damage to the spinal cord. It's just whether or not it's going to result in lasting permanent deficits. And we really want to get it taken care of before any of these things happen or get worse.
This might be an unfair question, but do we know what that time limit is? So say this person knows that they've had Chiari from day X, and how long can that person realistically wait to have surgery before maybe they should do something about it?
That's really tough, because everybody's different. When I talk about symptoms that I really don't want to watch or sit on, progressive scoliosis, a syrinx of any size, people who are passing out, having syncopal events, people who go paralyzed on one side of the body for 15 minutes, a half hour, several days, people who aren't able to walk, those are more ominous symptoms and signs to me that really need to be addressed. When someone says, well, how long can I wait? And sometimes the patients ask this. The issue is that Chiari causes gradual symptoms most of the time, and people get used to how they've been. So no matter how bad it is, a lot of the time they're afraid of surgery, because they're thinking, it's such a big surgery and I've kind of lived with it for this long, or I've lived like this. And they don't see, necessarily how bad it's gotten. If you went from normal, completely normal one day, to not being able to walk and not being able to move one side, and all of the Chiari symptoms, choking, gagging on food and liquids, dizzy, ringing in your ears, ear pain, throat pain, choking, you would be in emergency. You would be wanting an emergency surgery. But because things happen gradually, a lot of the time, people are trying to manage it and live with it, and I can't blame them for that. I mean, surgery is scary. Right. But the symptoms and signs that I've mentioned, I think, are ominous and really need to be corrected if they can be.
A question just came up that kind of gets to this. So how often do you recommend surgery? And if you don't recommend surgery, how often would you want to see the patient to come back to make sure that there's nothing progressing there?
Everybody is different. I'm not sure how many patients I see that I recommend surgery versus don't. That changes, I think on a daily or weekly basis, just depending on who walks in. And a lot of the time the patients have been already diagnosed by a neurologist or another neurosurgeon and sent to me. So, that's a hard question. I can say I don't recommend surgery, certainly for everybody. But when I see the signs that are more ominous, then I do. And I recommend it more urgently for those people within a couple of months. If someone has had symptoms ongoing for more than 6 months, they have more bad days than good. They're not able to function because of the symptoms, or they're not able to function without taking medications every day. for more than 6 months period of time, then in my mind, they are a good candidate for surgery if they have Chiari malformation. Medications lose their effectiveness over time. And then people have to be put on more and more medications to achieve the same effect. And then the medications have side effects.
Of course.
That said, about 40% of the time, this is where it really gets complex, about 40% of the time, Chiari symptoms will get better or on their own or completely go away. So everybody doesn't progress. Some people get better. I've seen patients who have, what I refer to as signs of having been very symptomatic. So you'll see someone who in the office who says they don't have any headaches, they don't have any pain. They were in a car accident, got a scan, and were found incidentally to have a Chiari. And then you look them over. They've got scoliosis. Maybe one hand is bigger than the other. There's some loss of muscle in one hand. There's nystagmus, but they have no symptoms. But then when you ask about all the other Chiari symptoms, they had, bad headaches in elementary school. They had a lot of dizzy spells like 10 years ago, but they just went away. There were Chiari symptoms over time that just kind of went away. And Chiari itself, the abnormality, the tonsillar herniation, can go up and down over time on its own. So, yes, people can get better on their own without surgery, but it's a surgical problem. 70 to 85% of people just across the country, across the world, get better with Chiari decompression. About 40% get better without. So there's no comparison to conservative therapy and watching people versus doing surgery. If you want to have conservative therapy, you don't want surgery, then you can be watched. And deaths from Chiari are rare. So if you want to be watched, you can, but you don't have to be. And there's no period of time that you're symptomatic with Chiari that you have to just keep coming back and coming back and coming back until finally, okay, we've watched you long enough, let's do it. Yeah. That's not my practice.
Do you notice that, trying to figure out how to word this, transient isn't precisely what I mean, but I guess in a way it is. Can Chiari symptoms, maybe after they've gone away, as you're saying, would, I don't know, 20 more years later, could they come back? And would it be due to, maybe it's not necessarily due to a trauma, but say there's a 50 or 60-year-old person and they had Chiari when they were younger, maybe they had a decompression, maybe they didn't, but then all those years down the line, suddenly they're having these symptoms again. They think, their physician even probably thinks it can't be from the Chiari that was taken care of. So is that something that happens, and what do they do in a situation like that?
Well, I mean, that person, let's say the person has had a decompression. In my experience, they're pretty determined that this is the Chiari. They know what the Chiari is. They know what it feels like. They know that they're having these symptoms again. And then they get imaging, and then they come back and they get evaluated. Sometimes they have developed hydrocephalus. Sometimes it turns out it's, a combination of connective tissue disorder, some other things, disc herniations in the neck, just a combination of things that are causing symptoms that look like Chiari. But those patients will usually be pretty determined to be imaged and be seen and evaluated. If someone never had surgery and the symptoms came and went over time, that's actually kind of the typical story. And a lot of the time, the symptoms they were having as children went away, but other ones came back or occurred as teens. Then those got better. Then they developed something else in their 20s, and then in their 50s and 60s, something else.
Mm-hmm. A specific question came in the chat. Have you seen Chiari patients, one of the symptoms specifically being vomiting? So I know nausea is very common, but is actual, I guess, emesis common as well? Yes.
Yes. Vomiting, particularly cyclical vomiting. Mm-hmm. When patients have our newest description of Chiari 0.5, or lateral medullary compression. So the cerebellar tonsils may or may not be down below the foramen magnum, but they are wrapped around the brainstem and actually squeezing the medulla on both sides. Those patients very typically have nausea and vomiting. They have vomiting, dizziness, and poor balance.
I have one really complicated question for you, and it's sort of related to brainstem.
Okay.
Can symptoms of narcolepsy with cataplexy be indicative of a brainstem or a cervical spinal problem, especially in someone with hypermobile EDS? Oh, interesting.
Yes, that was simple.
Yeah. All right. Well, so this patient,
but not the question.
this patient had a couple of central sleep apnea episodes during a sleep study, but the doctor said it wasn't enough to be concerning. So what should a patient do in that case?
Well, so is the patient has narcolepsy?
Yes, symptoms of narcolepsy, to be clear, is how they stated it.
Has the patient been decompressed or no?
I don't have that information. I'm not sure.
If the patient has not been decompressed, then I would bring him in and I would ask very detailed questions about any possible Chiari symptoms that they have. Because again, remember, people a lot of the time get used to their symptoms and don't even, remember them or recognize them anymore. I've had, several patients who said, no, I don't have headaches. And then I say, well, do you have a feeling of pressure at the back of your head all the time? Oh yeah, I always have that. And that is headache. But they have stopped even recognizing it as headache because it's been going on for so long, and it's just kind of become part of their life. So I would bring him in and I would ask him all the questions about Chiari symptoms and signs. It's really good if a patient like that comes with a parent, because the mom can tell you, yeah, he didn't walk till he was 2, and he was coming home from school all the time in elementary school with headaches and, different things like that. He couldn't swallow as an infant, different things that tell you this person is symptomatic from Chiari. And if it turns out that they are, that it's not only narcolepsy, then I would decompress the Chiari. If there really don't seem to be any other symptoms other than the narcolepsy, then I would, have neurology treat the narcolepsy or the sleep specialist and see if it gets better.
If anyone has any other questions, we're going to be wrapping up soon, but I did want to ask this because it's come up a couple of times. Patients, as you're saying, can get very used to their symptoms and it's just their normal, and that's tragic. But what happens and how often does it happen when Chiari symptoms or Syringomyelia symptoms come on very fast, very acutely? Because I'm sure that can be very, very scary. And at what point, how do you know what's an emergency situation for a Chiari patient or a Syringomyelia patient?
Yeah, that happens. I'm thinking of a 7-year-old girl who, had no symptoms, did a handstand, fell down paralyzed on one side of her body, and was, at least weak, paralyzed 2 week over about 3 days. It didn't just immediately go away. And she turned out to have a Chiari and massive Syringomyelia throughout the spinal cord. People have come in with presentations of stroke or a TIA and thought they were having a stroke, and it turned out to be Chiari. So no, the symptoms can just all of a sudden come on. Nobody knows why. Nobody knows why someone who's been asymptomatic, into their 30s, 40s, 50s suddenly develops symptoms that don't go away. But yes, it does happen.
So a question came in. Oh, it's a doozy. Does a released tethered cord have a higher chance to retether when a child has a pubertal growth spurt? So if they were currently retethered but not super symptomatic, could it physically cause them to not to grow as much? Oh, interesting. So can the tethering stop their growth or slow it?
Not that we know of, but if someone is tethered and doesn't get untethered, has a growth spurt, they are likely to develop scoliosis, and that will cause their height to be less. So the person's not growing less, but they may develop, scoliosis and be shorter from that standpoint. the spinal cord is untethered, and then the scoliosis straightens. I would wonder if it's known scoliosis in a growing child. I would really strongly recommend untethering it so that you don't have that kind of problem, worsening of symptoms. I mean, that's why we do it in young children, because as they grow, there will be increased tension on the spinal cord, increased stretch, and they can develop, problems like, foot abnormalities, curvature of the foot and ankles, trouble with walking, stumbling, and then the back pain and the bowel and bladder problems.
Mm-hmm. So is it more likely for a cord to retether after like a growth spurt in pubescence or adolescence?
Yes, and they become more symptomatic. So the spinal cord has been untethered right around any of the growth spurts, 2 years old, 5 years old, about 10 to 12, and then again 15 to 17. After 17, 18 years old, people usually don't grow much. There are exceptions, but usually they don't grow much after that. So then I typically see patients every year with that I've done a spinal cord untethering until they're 18. And then after they're 18, then they just come back if they have problems.
So I think to wrap up, I'm going to kind of come back to something we talked about in the beginning, where we're in this weird time where everything's being done by telehealth and people are seeing people across the world and across the country. So this is really a question, I guess, more for you and your practice. Are you doing remote consults? So maybe a patient in, like, I don't know, Montana, or even further, maybe Florida, or maybe they don't want to travel right now, but they are interested in seeing you. Do you do remote consultations in that way?
I do,
Okay.
and that's been very common right now with what's going on. I don't like to, I really don't operate on somebody that I haven't seen in person at least once. I prefer not to see new patients by telehealth, just because there's only so much you can do as far as exam.
Right.
And checking reflexes is important. Checking, sensory exam is important. Sometimes there are real logistic problems, but I pretty much insist on seeing somebody in person at least once before I do an operation on them.
Well, it's a very personal thing, so if you want the FaceTime, I would. But that's good to know. And I honestly, if someone was going to do something remote, now is almost the time to do it, because it's a little bit easier logistically, well, not logistically, but regulations wise, because they've relaxed a lot of stuff because of the pandemic. But that's good to know.
The best patients for telehealth are the follow-ups that I know well, that maybe we're going to make a decision about whether we need to order another MRI or not, or they're doing great, but I'm not likely to have to really explore anything that we haven't talked about before.
As a final question, if a patient who, especially if they were a patient of yours in the past, if they're suddenly starting to have some problems and they're scared to go to the hospital for all the reasons we talked about before, which they shouldn't, because I know the hospital is one of like the cleanest places right now, but how do they safely go about getting an MRI or in any sense like that? If they have to get some, I don't know, if it's tethered cord, they need urodynamics testing, what's the process for that? Is it something that they need to prepare for extra right now? And what would you say?
Yeah, I think you're right when you say the hospitals are among the safest places now. People really need to get their routine health care taken care of. They really need to get their imaging. They shouldn't put it off for fear of COVID. Every hospital that I know of, that I go to, has sort of designated COVID areas. And they work very hard to make sure that no patients with COVID are kept in non-COVID areas, even just in the ER, like from just walking in the door. So they're really doing a good job of isolating patients who might have it, even being suspected of having it. The X-ray and MRI techs are wiping down the machines, the tables, everything between every patient. Everyone is using masks and gloves, and it really is pretty safe. And it's more dangerous to have progressive symptoms and not get an MRI than to just go ahead and get it done.
Absolutely. Well, that was awesome. So I want to thank Dr. Gilmer for being with us tonight. And I don't know if there's anything you want to mention before we go.
No, thank you. Okay. Thank you. It was fun. I love talking about Chiari and Syringomyelia. I could talk about it all night. So thank you very much for your attention.
Thank you all for coming, and thank you, Dr. Gilmer.
You're welcome. Bye-bye.
Bye.